Welcome, everyone, and thank you for joining us today for the last session in the 2026 Donald Maloney, MD, Dialysis Leadership Medical Director webinar series. I'm Kelly Brooks, coordinator for the Forum of ESRD Networks, and I have a few housekeeping items to go over before we begin. First, please remain muted to minimize background noise and interruptions. You will have an opportunity to submit questions using the chat feature. You may submit questions at any time during the presentation, and we will answer them toward the end of the webinar. Today's presentation is being recorded and will be posted to the forum website for future reference. I will be sending out a survey link to an evaluation form. I'll put it in the chat and in a follow-up email that you will receive after the webinar. We would very much appreciate your feedback. So let's get started. I would like to turn things over to Dr. Daniel Landry, Forum President, who has some introductory remarks. Take it away, Dr. Landry.
Thanks, Cal. Welcome, everybody, and we're so glad to have you back for, as what Kelly mentioned, is the last of this year's lectures in our inaugural Donald Maloney Dialysis Leadership Medical Director Series. We've had a lot of fun doing this. We really appreciate your feedback, your thoughts, your ideas, things that we can do to make this better. We plan on coming back next year with some new adjustments and innovations as well. But at the end of the day, our sole focus here is to just try to educate the community at large, help our partners any way we can. And we really, as I said, really value any input that you have. So I want to thank everyone who's made this happen. Certainly, most importantly, Kelly Brooks, who makes everything happen here at the Forum of ESRD Networks. And as you may or may not know, we're a nonprofit group. We serve to really kind of help direct traffic, if you will, between the federally mandated ESRD networks that exist to make sure that the quality of care for all people throughout our nation is at the highest level. And then we also connect through other providers such as CMS and other people as well. So today we're really excited, as I mentioned, to have our last talk for the year. How to effectively round in the dialysis unit. And that's going to be given to you today by a dear friend and colleague of ours, Deb Hain. Deb is a medical advisory council member for Network 7 and also serving on the boards, on forums, board of directors. She has over 30 years of clinical experience as a nurse, as well as a nurse practitioner in the dialysis spectrum at Cleveland Clinic, Florida. She's also a professor at Florida Atlantic University. She's published over 75 manuscripts. And Deb is somebody that I would always go to for the kind of experience and insight in terms of the only the highest level of care for our patients. So, Deb, it's a real great pleasure to have you here today, and I'll hand things over to you.
Thank you, Dr. Landry. I really appreciate your introduction. And I was telling Kelly, I really love working with everybody on the forum. I don't feel like there's any hierarchy or anything like that. It's a wonderful place to be. So welcome everyone. I'm so excited that you're here. I appreciate this is something that's very near and dear to me. I have, as you saw, I worked as a dialysis nurse for many years and then as a nurse practitioner for more than 20 years and rounding in the dialysis center. So I first want to make sure you know there's no conflict of interest and that the photos are not from a third-party image and there's no patient's photos or identifying information on any of the slides. So why do we round? When we have a structured rounding, it really supports that patient safety, which is key to what we really are doing, trying to give them the best outcomes. We want to make sure it's a safe environment, that we have a dialysis team approach, and that we're able to identify early complications or issues that the patients may be facing, and then also to improve the clinical outcomes and really reduce some of the high risk factors that our patients have. Oops, sorry. So what do you evaluate when you go through a dialysis center to round? You're looking at volume status. What is the dialysis prescription? Is it appropriate for that patient? And then chronic disease management. Even though you may not be the one providing the care for diabetes, We want to make sure that we're collaborating with the endocrinologist or PCP, whoever is caring for that patient, and making sure that we're aware of what they're taking. I have a patient right now that I saw and for mental health, and he had been put on Jardians, and he's 80 years old, and he started dialysis, peritoneal dialysis, and he was losing a lot of weight. And I asked him, why were you put on Jardians? And he said, I don't know. And then I suggested that he go back and talk to his nephrologist. And of course, they took him off of it. Somehow it wasn't, this is part of the chronic disease management, is paying attention to what they're taking, why are they taking it, and do we need to stop it? And so they stopped. And last time I saw him, he's gaining weight. He feels better. So it's really important that we're aware of what medications that our patients are taking, even if it's not related to dialysis. And that goes back in the medication management. And particularly, we look at older adults and we consider deprescribing, appropriate prescribing. So are the medications appropriate for that person? Should they be getting that? Even if we're not the ones that are managing that medication, talking to your colleagues and making sure that this is the right thing for that person. And then the laboratory studies, and of course, psychosocial issues are very important, and I'll talk about them later. But most important is that human being sitting there in that chair and receiving dialysis. Whether this person is receiving dialysis at home, whether they're getting PD, whatever it is, the key is this person is living with kidney disease and required to have these treatments to survive. So really think about what they're going through. And I'm taking approach with human-centered dialysis, as this is my own terms. The human-centered care came from different references, but it's really about the human-centered dialysis, and it's shifting that focus from that protocol-driven, the rigid, like we've got to get their phosphorus to this level. Who's that person in the chair, and that individualized treatment. I had FA come one time, facility administrator come to me and say, can you get a fistula in this guy? He was AKI, and he had he had renal, he had liver cancer, and he had AKI. So I said, no, they wasn't looking at the person sitting there, and we're not going to have a fistula put in him. And he didn't even survive another week. So think about the person that's there and what we need to do, not just at those outcomes that we're trying to achieve, which are definitely related to payment, as you probably heard in other sessions. So it really it prioritizes a person's lifestyle, their goals, the biopsychosocial well-being, and it fosters that ability to be in shared decision making between the patient, their care partners, and the dialysis team, which includes the nephrologists and nurse practitioners, PAs, who also round on these patients. So what's the difference between patient-centered, person-centered, and human-centered? When we talk about patient-centered, we're talking about that illness. We're treating the illness. We may ask them about their values and preferences for care, but our goal is really that patient receiving the treatment. It's not focused on the holistic part of that person. Person-centered does that a little bit more, and it looks at, more well-being and the values, centers on the whole human being, and empowers the person to be actively involved in their care and what things are important to them, and promotes that independence. When we talk about human-centered, it's more of a way for it is more of a way to move away from prescribed targets, individualize individuals collaborate with their care, and you set mutual goals. And if you ask the person receiving dialysis, what matters most to you? What are your goals? That will help you as far as when you're talking to them and trying to establish what's important to them. We have an aging population on dialysis. And so asking someone what matters most, and I've done studies where people have said, in older adults receiving dialysis, and they've said, I just want to live long enough to see my granddaughter go to kindergarten. I just have this goal, my wife, when she dies, I want to stop. So they may have their simple goals. And then you might see someone younger who says, I just want a transplant. So how do we get to the transplant? I've done a lot of CKD education, and the first thing I would ask people is what matters most and where do you see yourself in the future? I want a transplant. So I would start with the transplant, whatever the goals are. So it's no different when they're receiving dialysis. What are those goals related to their life circumstances? You're taking a holistic approach to care, and you're incorporating all those biopsychosocial factors, including their socioeconomic status, support system, and cultural factors. And then you're prioritizing their treatment options that integrate with daily life. People have to integrate what they have to integrate what all the dialysis, all things that come with receiving dialysis into their life. What I've seen in my studies, and it's a new normal. They have to create a new normal. And often I hear patients say that it's a new normal. My life isn't the same. And so just to bring it home a little bit more, I'm going to talk about John. He's a 20-year-old male, and he one day came out of the dialysis center and he went in the bathroom and he came out and I was talking to him and he said, I go in there, I look in the mirror and I wash my face and I say, do I look like a patient? And when he walks out the door, he said, I'm not a patient. I'm a person living with dialysis. So he's incorporated in his life, even at a young age. So when you get in to go do round and you want to think about who, go meet with the team members, if there's a social worker, dietitian. One of the things that's important in dialysis, we've always had this interprofessional team approach. And so we've always had that access to a social worker to look at some of those psychosocial issues, the dietitian who can help you with nutrition, and the nurses, and we never want to forget the technicians. They're a wealth of knowledge, and you want to build that rapport with them. But when you come in, ask if there's anything going on. Is there anything you should be concerned about? And then evaluate their treatment related data, their flow sheets, different things related to their dialysis, and then their medications. What are they taking? What's related to dialysis and their laboratory studies? What do we need to change anything? Do we need to change the binders? And the social workers are there to support you with if you consider changing a binder, let's talk with the the dietitian, and the social worker can help with finances if that's appropriate. So you're at the chairside visit, and it's good if you could do it the first hour, but I find that it's very difficult to do the first hour because I would go to many different dialysis centers and I had to try to catch everybody before they came up. But it is the best, and I'll explain a little bit more about that as we go through this. But make sure you're communicating with the patient. And if it's appropriate, having the patient, you're looking at the patient, getting that eye contact. In some cultures, it may not be appropriate, but being aware of that. I've had patients say to me, the doctor came in and he hurried up and I didn't want to bother him. He looked like he was in him or her in a big hurry. So I didn't say anything. So you don't want to be that. I know that you may have a busy practice, but you want to be able to stop and communicate effectively. It doesn't take long. And asking what's important today, what things are you issues, and patients most of them are respectful of your time. And often what they would do is turn around and ask me something if a physician had come through because they were afraid to say something to the physician. But we don't want them to do that. And I'm sure you don't want them to do that. You'd like that communication. So taking that time and once again talking to the technician. I've had technicians who say to me, the fistula just doesn't feel right. Something's just not right there. I'm concerned about it. Even though the parameters, the venous pressures, the blood flow, everything is good. Cannulation, the technician was having a problem. So sometimes we would send them earlier to the vascular access clinic to look at that fistula because we know that's their lifeline and we want to keep it as long as possible. And they can tell you, I tried to take off more fluid with him, but he wasn't tolerating it. So they are a resource and they are first line. They build a great relationship with patients. So getting their feedback is also important. But I also go back to the nurse or whoever's appropriate, the other team members to let them know what might have happened with the patient, what concerns, and get their feedback and recommendations. So you want to do volume status by checking them for hyper or hypovolemia. You want to assess their target weight. Look at that interdialytic weight gain. What's the ultrafiltration goal you left for that day? And what are their vital signs? When we take vital signs, some of the patients just have such severe vascular disease, you don't get an accurate blood pressure when you're taking their blood pressure. So you're going to have to rely on symptoms. Decades ago, when I first became a dialysis nurse, we had patients that we never got a blood pressure from that because we couldn't get a reading on and nobody could get it manually or via the machines. So we would just ask him how he felt, and he would tell us. So always knowing that the blood pressure is one part and the heart rate is important. Those are important parameters to look at, but also that patient is very important and what they're feeling and what's going on. I had a patient one time that was had a dialysis catheter, and she was in the hospital for sepsis, and she was anephric. She had no kidneys, and the resident, the internal medicine resident, was pumping her full of fluids. He was giving her IV fluids. And she turned and said to me, Debbie, have him stop because he's killing me. So if the patient's telling you something, listen to them. They're feeling it. Some patients will say, I don't think that anybody listens to me and knows exactly how I feel when my blood pressure goes low. So make sure that they can trust us and that we recognize what they're going through. And then, of course, their access, we'll talk a little bit more about that, and then medications again. So when we're looking at their ultrafiltration rate, it's historically been made its estimated target weight, and we estimate that based on how they feel. And what is their pre-dialysis? What's that intradialytic weight gain? And so we look at those things, but now we know, even though patients may not have symptoms, but if they're having this hypotension and they may not have symptoms, they're still increasing their risk for cardiovascular mortality and for the risk of falls. So we want, and also for neurocognitive deficits, which I'll talk about in a few minutes. So we want to make sure we're looking at is it that, and once again, asking the patient, how do you feel after dialysis? When you go home, what do you do? I've had some patients where they go out to lunch afterwards. Others just go home and go to bed for a nap for an hour. Some go to work. So asking what they do and how they feel in between those dialysis sessions. And then have they attempted to lose weight? How are they eating? If they're not eating, or they've been sick in the hospital, they probably lost their weight, had lost body mass. And so we may have to challenge them a little bit to get to see where that dry weight is or target weight. So we really want the person in UV as best as we can to a euvolemic state as much as we can, but this doesn't always happen. Some people have a little bit more fluid, so we talk about having normal extracellular fluid for that volume for that person. And the dry weight is like I said, fun when people have hypertension, muscle cramps, other things. I actually had a patient years ago that would just all of a sudden just syncope. That was it. No warning at all. So we started watching for symptoms that he would have before he would have syncope, and he would just pass out, and he would yawn. So then we knew we needed to look at his fluid. Some patients will tell me, like I said, that no one's paying attention to them. They have to yell. It's not that the dialysis staff is not looking at them or paying attention. They don't want this to happen. It's that they're busy with something else and they may not catch it. So it also depends on how quickly you remove the fluid. More rapid fluid removal, more chance of having low blood pressure or having some of these symptoms. Look at that pre-dialysis volume, and of course their medications, and we'll talk about that in a minute if they're getting hypertensive. There is technology. I'm not an expert in this. I just thought I would mention it. I've never used it, so I can't give you a lot of information about it, but it's something that you would, if you're fortunate, you may have something in one of your dialysis centers, but you still need to pay attention to the patient. So when we look at volume-related intradialytic hypotension, we say that there could be those large weight gains in between the treatments. Decades ago, we used to give them hypertonics, high sodiums. They would go out thirsty and drink more, and then they would come back with the volume, and it would just, the cycle would repeat itself. And I was like, why are we giving this to this patient? They're gaining more weight in between. We always want to talk to the patient about their sodium intake, how much are they drinking, so just to make sure and listen to what they're saying. Years ago, we used to argue with them. They say, you drank too much. No, I didn't. Yes, you did. No, and that's not the way to be. It's really listening to what they say it is. Some people will sign off early and not get their full treatment, so then that weight accumulates. And then there's always that you need to change that dry weight. And there also is, like, if you have a higher dialysate, it could also cause that. People who have like neuropathy, autonomic neuropathy, the medications, typically when you have someone have low blood pressure in the beginning, it's related to that medication. And we don't let them eat during because there's a risk of hypotension and, of course, anemia. Dysfunctional cardiac factors, and uncommon are in the furthest one. I have seen patients with septicemia with really low blood pressure, so that should be a warning sign that maybe, somebody with a catheter, have they had a fever? And we know that in older adults, they may not have a fever right away because of the blunted immune system. We're going to watch for hemolysis. I haven't seen hemolysis since we stopped using different formaldehyde to clean the machines. And when I first was a dialysis nurse, we used to use formaldehyde. We don't do that anymore. And rarely do we see air embolisms, but you can definitely see any of these occur. Some things that have occurred in the dialysis center is that the patient pulls out their needle by accident and they've bled, or there's some disconnection and they have been bleeding. So the hemorrhage occurs. So we want to look at interdialytic and dialysis hypertension. Occurs in about, we know, 15%. I don't know how accurate that might be. And it's really sometimes can be that sympathetic and renin-angiotensin overactivity as they get closer to their at dry weight. You might see this. So you want to look at the overall treatment and not one. Typically, many times they will try to take more fluid off because their blood pressure is high. It wasn't that high when they pre-dialysis. Now it's getting higher towards the end. That might not be related to the fluid. And what happens is the blood pressure will go even higher once they get towards that end of the treatment. The other thing is we want to pay attention to anxiety. I have patients that I treat for anxiety who say that kind of in the middle of the treatment, they start to have anxiety, and then that causes their blood pressure to go up. And treatment of that typically is an SSRI. I give them either sertraline, or some of the patients will take Lexapro, escitalopram. And I don't recommend some of the other ones. I have a few patients that are taking bupropion, but really those two, sertraline is probably one of the better ones that I've used in the past to help with that anxiety-induced hypertension. This has been near and dear to my heart. Some of my research has looked at cognitive impairment and medication, ability to take medications as prescribed. So we want to be aware of when someone may have cognitive impairment. And the risk factors for cognitive impairment are CKD, receiving dialysis, those patients, and hypertension, diabetes. Those are important risk factors. So anything vascular, so they can have vascular, which would be that white matter disease, and they may have vascular changes, which is more of a stair-step pattern wherever that microinfarct occurs. And then we want to think about those older adults that may have Alzheimer's type dementia as well, but early, so we can have a mixed profile. The important part here is that it can affect executive function, and that is that planning, organization, self-control, and adaptability to change. And they may struggle to take their medications appropriately and follow the diet as they're supposed to, as they are recommended. So for example, I had older adults that I would give them instructions toward the end of dialysis, and then they would call the office and say, "Oh, I'm supposed to get something." And I'd say, "Well, I already, we talked about it. I already put the prescription in, those," but they don't recall. What may happen is that they are not storing and encoding it correctly, so they're unable to retrieve it at a later time. Even if they can give teach back and say, "Oh yes, I need to take 3 binders, I need to do this, I'll follow what you said, I'll go to the pharmacy and get my prescription," they may not recall it once they go home. So we have to find other ways to make sure they're aware, rather than calling them non-adherent, but rather finding out what might be who could we talk to. In my case, I would talk to my patients. I would talk to the family and say, "I just sent your dad or your husband home with XYZ, and so I just want you to be aware." So thinking outside, the best time for them is once again in the beginning. But we know what busy instructions is in the beginning of treatment. However, we know we're in a very busy dialysis center, and they may not get the instructions till the end when cognitive function is not the best. And you often see in the beginning the patient's alert and they're very, their normal self. And then towards the end, you see cognitive slowing. So their speech is slower, their mental processing is slower. And this is where you can see that they probably they may have cognitive impairment. Vascular type is most common in our patients. So they should be evaluated. Some things that you could do, and I wouldn't do it while they're on dialysis, but rather if they come to your office for anything, if you think this may be an issue, you want them in the best state of mental health. So the best time for them is beginning of dialysis and then the next day after dialysis. So right after dialysis is not a good time, or towards the end of the treatment, to evaluate cognitive status. So the Montreal Cognitive Assessment, which is this one here, which is I like this one a lot. One of the things I like is this is trails A and B. Trails. This is a good evaluation of executive function. And then this also, when they draw the clock or anything they're required to draw, is also a good evaluation of executive function. I found in a study that we did with older adults going discharged from community hospital to home with home health care, we looked at the relationship between medications and errors and their cognitive function, and we found that it definitely was related. And the one thing that was really significant was the clock drawing. So I love the clock, and so it's very important that you look at executive function, because that's usually what is affected by dialysis and the other comorbid conditions they have. There are also some mini-cog, which is asking them to say 3 words, draw the clock, and then repeat those 3 words. This is what we did in our study, and the clock drawing was what indicated there was possibly executive dysfunction. The other thing which is really important, and I talked about this, is paying attention to your patient's risk factors for falls. I do legal expert witness, and most of the cases I have right now are falls in dialysis centers. And even though the patient, you have to look at the risk factors and have them do a good fall assessment, being aware what are those fall risks. Making sure you're aware that their falls may not occur in the dialysis center, but outside the dialysis center at home, and that's significant as well. So always for asking the patient, have you had a fall in the past year? If yes, explain why. Do they feel that they have difficulty with their gait, with their balance? And making sure we do a comprehensive evaluation, because they fall because of dialysis-induced changes, fluctuation in their blood pressure, they get hypotension, that rapid fluid shifts, muscle weakness. They also have it for physical deconditioning, so anybody who has frailty would be a risk of falls. And then those are taking any kind of antidepressants, sedatives, medications that can affect their postural stability. And then bone health, of course, puts them at risk for an injury. So always think of if it's injury or not injury, but making sure you do comprehensive evaluation and making sure the staff does it before they're I don't know how often, depending on that policy, but asking those questions about fall. Because I had a patient one time who said he had bruise on his arm, and I said, "Did you fall?" He said, "Yes." And I said, you didn't tell me?" He goes, "It had nothing to do with dialysis." So being aware of the falls, if the risk factors there. So when we look at adequacy, which is something you're also supposed to look at, we use the single pool of KT over V. And if you see someone has a low serum urea level, it could be due to they're not eating, so they have a low protein intake, and so they don't have that much to really remove. We want to consider residual kidney function, and we always want to protect that kidney function. So trying not to be so aggressive in fluid or causing any hypotension, and of course any nephrotoxic drugs. So any residual kidney function is important for that person. So if we can keep it as long as they can, that would be great. And you want to consider that when you think of clearances. When you're not achieving the clearance, we want to think about, did they have their blood flows decreased during the dialysis? Did they have to get off the machine? Were they having hypotensive episodes? It could be also that they're a very large person. And so you want to pay attention to what's happening during dialysis and with their blood flow and the treatment itself, if you see that they're not meeting that. So the dialyzer plays, and the dialyzer is an important factor, the time that they're on dialysis and the volume to be removed. So we look at access. You're not going to be able to do a real comprehensive assessment because the patient will be on the machine and they already been cannulated. But once again, talk to the technician or the nurse. And when you're rounding, consider any issues that they might have had with cannulation, or in evaluating the blood flow, arterial and venous pressures and their trends. I had a nurse one time call me and say her venous pressure is high. Well, it's been high. Why has it been high? Why is it higher? I don't know. So we got to see the trends, because if we're going to send them to a vascular access or a surgeon, or we want to make sure that we have aware of what might be going on with that patient. So were there any challenges with it? What are their pressures? And look at them trends over time. It's not just one treatment that you see this. Maybe it's they had a new person cannulating, and so they put it in a different spot. They need to, and be aware, like I just had patients say to me, I have thinning here on my fistula. And so I said they really should be rotating this. Make sure you discuss this with your nephrologist. Medications, what are they receiving? Also know what they're taking at home. Sometimes they won't tell you they're taking things at home. I gave you the example of the Jardians and the older gentleman. And so, I don't think they were aware that he was taking this. I also had a legal case where the patient was receiving metformin, and I won't go into the whole case, but no one noticed that he was taking that medication. So being aware what they're taking at home and make sure it's on any supplements. We did a CKD clinic one time, and people brought in lots of protein, all these different things that we wouldn't want them to be taking and over the counter, because somehow they think over the counter is good, but it's not always good. So be aware, especially if you see hyperkalemia. Are they doing anything different, or are their phosphorus is high? It's not getting to goal. So being aware. When we think about phosphate binders, it's really important to find out how they're taking them. But if you don't build that relationship with them, they may not they may tell you what you want to hear and not what they're actually doing. An example is there was a suggestion box for patients, and one patient said, I'm sick and tired of being lectured at. I don't want to take. I want them to tell me anymore. So when I saw the dietitian coming, and I pulled out my piece of paper, and I thought, okay, she said, how many are you taking? 3, because he had on the paper, he really wasn't taking that. So understanding this is hard. Patients will say to me, when I first became a dialysis nurse, I used to be in the same mode. Well, kind of that hierarchical that was the way it was. And I learned that that's not the way to change behavior. So now when I walk in a dialysis center, they're like, hey, Debbie, my phosphorus is going to be high. I don't even see their labs yet. That's a relationship you want to have. So I say, what happened? Oh, I went out to dinner. I forgot my binders. Do you need anything, any help? Nope. And the other thing is education is good. You need education to change behavior, but it does not change behavior. So building that relationship of trust and understanding that this is a hard life to live, and some patients are really struggling. And one man wasn't taking his binders, and he said, I stopped doing it because all they do is lecture me about what I'm supposed to do and not realize I'm trying and I'm slowly getting to goal. And then also always about their blood pressure medicines. You'd be amazed what you go in the home and find with people. If you don't know, like your question, is this med dialyzed or not? This is a good reference. I have an app on my phone. It's a great reference for that. You can pull it up on your app and be able to say, oh, this is not dialyzed, or they don't know if it's dialyzed out. So we talk about social, psychosocial. Those are the social drivers we're now. So more of they often called determinants, but drivers are more that the person has control over this. And so we always want to think about housing. Are they homeless? Are they struggling to pay their mortgage or rent? Food insecurity. One of the patients said, I went to the food bank, and they don't have anything I can eat. This is not on my diet. So nephrology nurses and others are trying to change some of these things so there are kidney disease friendly foods in these places. How about transportation? I don't have any transportation, or I drive myself. I had a man in my study who said he drove himself. He didn't drive himself to dialysis because his daughter was very concerned about him. However, he would drive himself. He'd get home from transportation and he'd drive himself to a restaurant. And so she only said dialysis. Be clear that it's not driving at all, if you're concerned about that patient, particularly after dialysis. We do have transportation available for them. Sometimes it can be challenging. I've seen some patients wait for a little while and they really want to go home. But it still is available for them. And the social worker can help you with these things. And ability to obtain their medications. Do they have the finances for them? Do they have access to get to the pharmacy? So we want to think about those things, and the social worker can help you with that. And then mental health. My other position, I'm a psych mental health NP, and I see people on dialysis for mental health. And we have a lot of patients with depression, anxiety even more, I think, than depression. And then those with serious mental illness, such as schizophrenia, bipolar disorder, and severe major depressive disorder. So you want to make sure you're collaborating with the mental health providers so that we can do the best for our patients. It really makes a difference. One of the outcomes we're looking at in the practice, the psych practice, is are they attending their sessions? Are they going, and I've had people now attending their sessions on a regular basis because they're treated for depression. We know that depression can lead to poor outcomes, such as their labs aren't going to be the best. They're not taking their binders. They're not taking their medications as prescribed. They're not showing up for their dialysis treatment. They're signing off early. So we want to look at consider that as a possible reason why people are not doing what they should be doing, or then are that I shouldn't say should be, but more in their best interest. So now we'll talk about you've seen the patient, you talked about their labs, you look at their meds, you do all the things we've been talking about. Now you have to document. Well, it's very important that it's a structured progress note so that you can bill appropriately. And we'll talk about that for the next few slides. So when the minimum required visit is once a month, and you can see here the billing codes, the optimal one is 4 or more, and one of them has to be a physician, and the other ones can be a nurse practitioner or a physician assistant. And you can see here, but one has to be the physician. And the more you see that patient, they never used to be this way. So when I first became a nurse practitioner, we didn't have it this way. And so, but once this changed, we saw more nurse practitioners and PAs in dialysis centers help supporting the team and the nephrologist. You have to document, it's a monthly capitation payment note. That is very important to do. This is the reference here. As I said, that you have to be the one to write this monthly note. Specific criteria are in that note, and it is billed under the physician. So that note has to be a face-to-face encounter at least once a month. The telehealth does not count. It is the assessment of the dialysis, so treatment tolerance, access site, adequacy, as I just went through, medications, care plan review, and that is talking with the team for that care plan review. It is not a one-person care plan review. It involves the dietitian, social worker, nurse, and the physician, and then if there's nurse practitioner, PA, those as well. So this might just a little example to say here, this is the subjective, how well are they tolerating? No acute complaints in between the treatments. What is the objective data, which you've already talked about? How about what's in the assessment plan? What is their diagnosis? What are comorbid conditions you might be looking at? What is their blood flow, the dialysate? You want to have that in there. The medications they're taking. I meet them I meet them once a month. Sorry. I do the 3 times a month for the nephrologist, but when I would do these rounds, I would make sure that I have patients that are on that I have the dietitian and the social worker, so we would do walking rounds. In some cases, you're meeting with the team as you in a meeting room before. It depends on what they're doing in that dialysis, but you really should be meeting with the team to come up with these things for the billing. I mean, for documentation that supports what you did and then the billing that you're doing. And you have to do an attestation where you say you perform this face to face and that the plan of care was reviewed and managed accordingly. So collaboration, I talked about the team. It's really important that you work with them. There's evidence more and more talking about interprofessional teams. Here at my university where I work, we have a very strong program where we work with medical students, nursing, social work, and pharmacy. And they learn how to do interprofessional communication and work together as a team and being able to communicate effectively and know what each other's roles are and being able to talk to them. When I first became a nurse, I don't know how many physicians I had yell at me. and for no reason, just they had a bad day, and that's how it was at that time. Now that's changing as we realize that it's so important to work together as a team to get the best outcomes for our patients. And so we want to value each person in that team, which also includes the patient. That is part of that because we're making sure that the person is central and that we are talking with everyone else that supports that person to get the best outcomes. This is my belief, you can follow whatever leadership you want, but coming from a human-centered, which fits with my human-centered dialysis, it really prioritize everybody and really hearing their voice and their motivations. You can benefit from what an expert in nutrition has to say, or a social worker whose expertise is in all the social drivers of health and psychotherapy. And then you have the nurse who's there from a nursing holistic approach. So rather than top down, we're really working together to empower each other within the leadership aspect within the dialysis center. So don't micromanage, make sure that you're trusting the team to work with you and they have ownership of their work, balancing and for productivity, but making sure we're aware of what the needs are of that team. Many times people don't feel valued, their voice is not valued, and we know that if they don't feel valued, they're not going to communicate effectively. We want to be able to trust and know that everybody's not perfect. I worked with several nephrologists who are wonderful, and I know that if there's something I didn't do or something, I don't know, if I took ownership, he was very appreciative and he said he trusts me because I would tell him things I didn't, I forgot to send that that medication for the patient. So being aware people are human and that we all make mistakes, but being there to support each other. So being empathetic, listen to everybody, that's active listening, recognizing them as individuals rather than just as the nurse, the social worker. This is your job. How do we make the best outcomes for our patients? And people have to have psychological safety to be able to talk to you. If you're afraid to say anything to you, they're not going to tell you. They're going to wait till the very last minute to contact you because they're afraid that they're going to get yelled at or it's the best way is to really take their ideas, unconventional ideas, and maybe that's going to work for that particular patient. So what are the key takeaways from here is being authentically present, active in listening to your patient. In the College of Nursing where I work, we use this caring philosophy. It's not of active caring, but philosophy. And so all persons are what our founding dean was the dance of caring persons. And so everybody's in the dance and the rhythm is good. When you step out of the dance, the rhythm is off. And the central person in here is the person being cared for. And that is the person and their family, the person receiving dialysis. What are their choices? What do they think will work for them? The best thing, I was talking to Kelly before we started, and the best thing we talk about, home therapies are the best. They are very good. Transplant is excellent for people. I mean, those are good options, but not everybody wants them. I have a patient right now said, I don't want to do home therapy because dialysis in the center is the only time I have any socialization. And we know in older adults, socialization or lack of socialization, lack of social connection leads to loneliness, which increases the risk for mortality. Safety is number one. You've heard this before. We want to make sure everybody's safe. If you see something, report it, communicate with the nurse there and who's ever in charge. Is making sure we do the best. There's times I've seen where I've gone to the facility administrator and said, I don't think this particular nurse is safe because we know that if there's any bullying to the technicians, that they're not going to report to the nurse as well. And actually wrote an article about that and a situation where the technicians were afraid to say anything to the nurse. And so they never told her things that were going on with the patient. That's a risk for that patient. There's a risk there. Are they using the right dialyzer? Are they using the water? What are they doing with the water treatment? How are they setting them up? Are they using all of the safety, the infection control with the catheters, with the access? Are they doing what are the safety issues we need to be aware of? And then, of course, once again, human-centered care and using person-first language where we have the person living with dialysis, the person with diabetes, what not the diabetic. The disease first. The disease does not define a person. The person is living with this. They're doing the best they can, and our role is to support them on their journey and to make and to be and to not label them, but rather discover what might be going on that that causes challenges for them to engage in their health and not take their medications appropriately, or not, could be that they're depressed, could be that I had one gentleman who missed his treatments. He was missing quite a few, but he's a young guy and he has a family, and his priority, what matters most to him, is him supporting his family. So he works, but he also misses dialysis. So now we've worked together with a nephrologist, and he's coming twice a week, and he's still able to carry on his job. He sees me for mental health, and I see him when he's in his truck, and he pulls over and we have a visit. And so thank goodness mental health is still telehealth, because I don't think we'd capture many people. But it was the nephrologist or the dialysis team who sent him for mental health. And so now he said he made a deal with the nephrologist. He would go at least 2 days a week. He does want a transplant. We've talked about that, but his priority is his family and making money. We want to do human-centered leadership so that we're think of everybody in that team and we support each other. And you will get better feedback from the dialysis team if you do that. And you can't make decisions totally make the best decisions without the support of everybody, because you're not there 24/7. And you're not there every dialysis treatment, so that you rely on others to give you that information about how that person's going. And once again, that person. So I want to thank you. This is my passion. I have been doing this forever, and one of my goals is to make sure that people get the best care on dialysis. So I'm open to questions. I see there's something in the chat. Oh, okay.
Deb, thank you so much. That is what a terrific talk. And, obviously it's one of the nicest things I knew coming into today was that your passion would show through in terms of what you do and how you care for people. And, I think that oftentimes nowadays we hear a lot about quality metrics and different things, and your ability to kind of describe the fact that keeping the patient first, understanding what their areas of focus and what's important to them doesn't preclude us from giving them the best quality. It actually allows us to get the best quality, right? So anyways, thank you for that. I want to start off, if you don't mind, by asking a question. And as you mentioned, if anybody has any questions, feel free to just put them in the chat. But I was kind of curious if we could delve a little deeper into your prior life as a dialysis nurse, and then how you've over time moved to the level of a nurse practitioner in nephrology. And I'm wondering, is there any particular advice maybe you might offer people here today, particularly some people who are maybe newer in training and all, when it comes to rounding in a dialysis clinic, that, something that you appreciated so much from a nursing perspective, and realize kind of that you can see some gaps occur when you're a provider now doing that rounding, things that you really would want to have as a priority, something for people to really keep a focus on.
I think for me, the biggest thing has been early in my career. I told you I came from an era where we were yelled at. I was in a community dialysis in a hospital, and I thought, well, that's going to stop, because I'm a human being too, and I don't deserve to be yelled at. And I think medicine has changed now. We're more collaborative, we're respectful of each other. So that has changed. I definitely have seen that through the time. But the best thing, number one, is collaboration with the nephrologist and the dialysis team. That, to me, working with everybody, as I said, even as a dialysis nurse, I respected what the technician said. The other thing is, when I first learned dialysis, I think it was a predominantly Black community. And I was myself and one other person were the only white people there. And I was the charge nurse, but I had little control, because they had to accept me. They had to trust me. And until they trusted me, were they going to listen to what I had to say? So we have to humble ourselves to go into these centers and be humble, and knowing that they don't know who you are. Why should they trust you? they may not be rude to you, but they need to be able to trust. And I remember a woman from Jamaica, it was giving me a hard time every day. And one day she came in and she brought me Jamaican food, and I knew she trusted me. So when they trust you, they're more likely to hear what you have to say. And trust comes from you knowing what they're going through. What's happening in their community? What's happening to them? Those are the things that I think are so important and I've learned throughout the years. And sometimes you just have to, as a nurse practitioner, sometimes I have to just pull up that chair and sit for a minute, eye to eye with a person, because they're struggling and they need to know that I'm there and I care. And I had a nephrologist I had worked with a long time ago, and he said, "You always take your time with them." And I said, I don't have a lot of time, but I make sure I take that time when they need it. It's not just standing there over there and say, "How's your treatment?" But are you seeing something that's going on? And I'll give you a quick story. I used to take the fellows. Now I don't do that anymore, but I used to train the nephrology fellows in dialysis. And I would take them first to the chair and introduce them to the person and tell their story. Who am I? And then I would take to the chart and say, okay, let's go back to the chart and look at everything else. And one of the patients said to me, "Do you know everybody's story?" I said, "Absolutely." And so knowing who that person is, what struggles they may have, is going to benefit you when you're trying to make those choices that are best for the patient and to achieve those outcomes, and not just focus on outcomes first and say, "Oh, we got to get the phosphorus in control. We've got to get the KTOV. We've got to do all these things because they're related to, it's value based. We know that there are outcomes we're going to get reimbursed, but rather start with that patient first, because that person, once they trust you and they're working with you, they're going to most likely do with what you recommend, and you understand their lifestyle, what's going on. That answer your question, Dan?
100%. No, thanks, Deb. I really appreciate that. And I think kind of following along that same concept, again, as we know, I think we have a lot of people here, thankfully, that are newer into whether it be training or in early career. Um, I realize that I think this is an art, not a science, right? In terms of rounding in a dialysis clinic.
Yeah.
There's no one size fits all. But if you could put yourself back again into someone who's kind of starting in that area as a new clinician or new nephrologist, certainly understanding and knowing the patient, what's important to them, far and away has to be the priority. But could you also maybe offer us just a few thoughts in terms of what to you is a wise, efficient approach to seeing your patients on dialysis? Because as you said, we're all challenged with time, and yet at the same point, we want to make it most effective for the patient.
Yeah, I think the one thing you have to be, I talked about the team. You can't come in and know everything that's happened with that patient, but knowing that the team can come and talk to you, having that relationship where they feel comfortable. And I talked about the dialysis technicians. They are the first line to see, they're with these patients and they know them better than probably anybody does. So, asking them, getting their feedback. So when you build those relationships with them, I would have technicians tell me, I didn't even have to ask, they would tell me, because they feel comfortable, they feel comfortable coming to me and saying, "Hey, Debbie, I seen this with this, I'm worried." And then, of course, making sure everybody, that's a building of that team, because then you get that information from them before you see the patient, what's something you need to focus on, because typically you can't spend a lot of time there. And also, as I said before, working with nurse practitioners and PAs, because you will see them that once a month. But I'm also, when I go in, I'm the eyes and ears for that nephrologist, and I am making choices. And I would always communicate with the nephrologist, and he would say, "Debbie, you don't have to tell me, because I know I trust you." And I'm like, "I know you trust me, because I wouldn't work with you if you didn't trust me. We didn't have that relationship. But I want you to know in case you see the patient." So not everything, but if there was something significant, I would make sure that the nephrologist was aware before they even went in the dialysis center, or to make sure, because I want that's that team effect that you have, that interprofessional team, because they're going to support you. And once they trust you, you built that relationship, they're going to give you information. I'm sure you find that when you go in, that it's the team that's telling you, "Hey, something's going on," or before you see the patient. I think that that's an important part.
100%. And of course, too, you know, you mentioned that relationship, that kind of culture that you build. I know Dr. Maloney mentioned here that the human-centered behavior is also ideal for creating an environment for successful leaders. And you know, and that again, I think it really kind of hits at the heart of what we're trying to achieve here through this lecture series, is to help build the next generation of leaders and to give some thoughts and advice and education through that effort. So,
Yeah.
does anybody have any other questions
I think the other
here?
thing real quick, Stan, is to say is that advocacy is very important, and advocate for your patient.
Yep.
You know, it's really, really, and for the staff, you know, if you see things and it's not good for fair to them, you know, reporting it to the facility administrator, you know, and that's important that you have that as well.
In
And
this day and age too, right? How many patients do we run into who don't have reliable primary care or the ability to gain access, or never mind the fact that, you know, the better part of 3 days of their week are spent in a dialysis clinic, and we, you know, oftentimes it's easy to kind of pretend to say, well, gee, they have plenty of other time to get things done when they don't. So, you know, I think that humanistic approach, that ability to kind of recognize, um, you know, and not to, I always say not to pretend to know what it's like to walk in these individuals' shoes, but at least to have an appreciation for it, I think is really critical.
and hear their voice, hear them, and authentically, meaning that you're there to hear them, you're there to listen to nonverbal and verbal, not just, oh, you know, you may walk in and the patient doesn't look the same, that something is wrong, and I had one, and I'm sure you have many, many stories, and he had a catheter related infection, but wasn't febrile. So, you know, because he went to a walk-in clinic and they gave him antibiotics and it wasn't enough to treat it. So sensing what's wrong, when you know that person, you'll sense that things or something's not right. You know, if you know them well, and you're like, okay, follow that. One of the nephrologists just say to me, Debbie, what is that thing you do? You caught so many things. I said, I don't know what to call it. It's called nursing, I guess. I don't know. Because you know, he would say, I don't think the labs don't show. I go, but I know something's wrong with that patient. And that's from knowing the person, that and knowing when they don't look like themselves, something is wrong. Even though the parameters are okay, you may see something in that person that you just suspect, and take, you know, trust your gut. Trust your gut, because that's the important thing, is that something's not right. Let me investigate further. Anybody else have questions? Oh, hi,
Dr.
Andy.
Howard has his hand up. Andy?
Hey, Deb, excellent presentation. Thank you. Just wanted to comment. I know you're aware of this, but just to make sure the folks listening are, two of the areas that you brought up, I wanted to reemphasize how important they are. Ultrafiltration rate as it relates to estimated dry weight, and of course, social determinants of health, all those things outside of the dialysis facility that impact patients' access to medication, food, transportation, housing, how they can critically impact what goes on. Unfortunately, I won't go into it now, but CMS elected to remove all that. So beginning with this year, payment year ultrafiltration rate out, and of course next year, which is what happened in 2025, already done the social determinants of health out. But I wanted to emphasize how appropriate it was for you to highlight those areas in your presentation. So thank you.
Thank you, Dr. Howard. Thank you. I appreciate it. Okay.
Well, it's East Coast time 1:58. For others, it might be a little different, but the bottom line is 2 minutes before the hour. Deb, can't thank you enough for what just such a wonderful talk today, and every bit as important. I hope people here also got a chance to really just see what leadership, what experience, what truly the care of a patient looks like. And I think that's something that we really, as leaders and future leaders here, and need to really make sure that that's a major focus. You know, we're gonna learn over time how to treat glomerular disease and how to, you know, make sure that we have the right dialysis access in people. But I think taking the time to listen and knowing really what's important for the patient, that's still has to be the central focus of what we do. So, Deb, thanks for highlighting that today. Can't thank you enough. There's a survey link, as you can see here in the chat, as well as one coming to via email if you registered. And I certainly encourage everyone to please give us as much feedback as you can. We just want to continue to make this better, more helpful to all of you. So please share with anyone you know. The talks are also posted on our website for the Forum of ESRD Networks. They're free, of course, all available to you. And the other thing too is I will also make the plug to say that we are a volunteer organization, and any act of generosity, kindness to help support that is always appreciated. The link, as you can see, is here as well. But otherwise, I want to thank you for a great first inaugural season to the Don Maloney Lecture Series. It really was a terrific one for us, and we look forward to seeing you back next year and with some updated content and some little bit of some changes. Okay, but thanks again, and wish everybody a great day.
Well, thank you very much, and I appreciate everybody on the forum to having me speak, because I think this shows that the importance of collaboration as an interprofessional team. So thank you when you live it and you can speak about it, right? Thank you so
Sure.
much.
Thanks, Deb. Thanks, everyone.
Okay, bye-bye. Thank you, everyone. Oop.